Thank you, Ralph. It's a pleasure to be here. Actually, I'm quite honored to be sandwiched between that very distinguished panel you just heard from, and also in particular the speaker that will follow and other speakers you'll hear today and tomorrow. What I thought I would do, what I was asked to do, was to give you a perspective about sort of a research agenda that NHGRI, the National Human Genome Research Institute at NIH, very much sees as a key part of its mission that is incredibly important for, I think, generating important data that will be very relevant to the talks and the topics you'll be hearing about. As you've already heard from the previous panel, I think many of us look at sort of the last 10, 11 years of perspective, and clearly that's a very important one for our institute. We were created by the US Congress to lead the US's effort in the Human Genome Project, and when the Genome Project ended, of course, we redefined ourselves to sort of take on the next research challenges in genomics, now having in hand a sequence of the human genome. And Jay Flatley very nicely reviewed some of the major accomplishments that have taken place in the intervening 10 years, a number of which NHGRI was a major funder of or a major participant in. But of course, what I want to focus my talk on very much is underlies the fulfilling the promise of why we have the Human Genome Project. And of course, it's very much the focus of this meeting, and that of these clinical applications. We think very critically at NHGRI about seeing ways that we can lay out a research agenda to be able to implement genomic medicine. The definition that we use of genomic medicine, the phrase we tend to use, is actually quite narrow, and deliberately narrow, so we can keep a laser focus on the challenges and the opportunities that NHGRI could make the greatest impact in. Now, the genomics community in general, and NHGRI more specifically, has always been guided by a series of strategic plans that lay out a vision for the next interval of time. This began at the beginning of the Genome Project and sort of continued even beyond the Genome Project. Our most recent strategic vision was published a couple years ago, but unlike the other ones, very much embraced this clinical applications of genomics as sort of the ultimate goal that the Institute saw for its research portfolio. So I want to really lay out very quickly for you the framework that sort of underlies the strategic vision that we are currently operating under, because it very much described in that strategic plan this vision of making a progression from the base pairs of the Genome Project to the bedside of patients and the realization of genomic medicine. And in leading up to the creation of that strategic plan, what we heard more than anything from the community that we engaged with over a number of months and through a multifaceted component was a description of a series of progressive domains of research activity that would inch you closer and closer to the realization of genomic medicine. The most proximal of these research domains were the one we were the most familiar with, which was understanding the structure of genomes. And even the next one had still a very basic science interpretive component of understanding the biology of genomes, basically understanding how genomes are put together and how they work. More sort of contemporary for the Institute was moving beyond genomics and recognizing that if we're going to get to genomic medicine, we need to understand the genomic basis of disease. And really this became the center domain of this 5-domain progression. New for NHGRI was starting to build a research agenda that started to tiptoe into medical science, actually using genomics research to advance the science of medicine. And interestingly, and actually very consistent with what you heard about from the speaker earlier from Stanford University, we recognized there was yet a 5th domain of research activity we needed to support, and that was to use genomics to actually demonstrate you're improving the effectiveness of healthcare, not just simply having a medical advance, but that when implemented in a healthcare delivery system doesn't do much good. So these 5 research domains, if you will, now become a framework that we use for thinking about everything that's going on at the Institute. We continue to be significantly committed to understanding these first 2 domains, basic genomics, really still a lot more to learn about how the human genome actually works. Probably the greatest investment we have at the present time is in this middle domain, which I would categorize as discovery. I don't think studying the genomic variants underlying disease is quite genomic medicine. It really is much more in a discovery mode, but one that we are investing considerably in, along with many institutes, the National Institutes of Health. But a focus for this meeting and what I want to briefly describe to you is what we're doing in these last 2 domains, and it's these 2 domains that I think fall very squarely into what we define as genomic medicine or personalized medicine. Now, what I want to describe for you in particular are what I would contend to be the hot areas as far as NHGRI is concerned in genomic medicine. All of these areas I'm about to describe are going to be expanded upon by other speakers at this meeting. But what they represent are areas that NHGRI is voting with its feet. These are where we are putting our research dollars in investment because we think that the hottest opportunities for seeing genomic medicine become a reality. And I would also point out that in almost every single case, we are not doing this alone. We are partnering with other institutes at NIH and other funding agencies, in some cases around the world, to see this happen, recognizing this is far more expansive than what one institute would do at the National Institutes of Health. And most important, what I want to describe to you in these 6 areas are what we see our mission and our purposes is to stimulate the field forward in areas that all of you are interested in, but by laying down a research agenda to stimulate some early activity to better understand that domain before it actually finds its way into the actual practice of medicine. So what are the 6 areas in particular that we see as some of the hottest? I would have to start with cancer, which is not surprising based on what you've heard from speakers already and other speakers you'll hear in the future. We have, as you heard Jay mention, have a significant investment in cancer. We've done jointly with the National Cancer Institute a major discovery project called the Cancer Genome Atlas, which is also similar to discovery projects going on around the world. But as we think about moving this into the clinic, we want to see genomics become as standard as radiographic imaging. And imagery like this, of actually having maps, comprehensive maps of tumors' genomes based on sequencing the genome of that tumor, becomes standard practice in medical care. We are partnering both with the Cancer Institute and thinking about other things going forward. But some of the other programs I'm about to describe to you are using as a test case, if you will, cancer genomics as some of the most compelling opportunities one could envision for applying genomics in the clinic. But we're not the only ones recognizing this. We see this everywhere. I would just show on the next slide a given website, and I'm showing this not so much to endorse this particular cancer center, but just to point out the quote here, genomic testing is the future of cancer treatment. It is my belief, and actually many of us at the Institute, that cancer, which so many people encounter in their lives, either directly or through family or friends, cancer might be the circumstance that people start really using the word genomics and trying to understand genomics and the concepts behind it, which is an issue of genomic literacy that we're also quite interested in as well. It's really becoming, I think, the cancer may lead us to having genomics be part of the lexicon of medical language that's going to be very important for us to be cognizant about. The other really low-hanging fruit in genomics and applying it to clinical medicine, as you've also sort of heard about already, relates to pharmacogenomics. Even the last story you heard from Jay Flatley for the disorder that he has now discovered. Understanding what we are predisposed to with respect to medications or medical treatments. And where once upon a time it seemed that we would make slides like this and be able to say, oh, we should be able to stratify patients and find those that are not going to respond well to a medication or have bad side effects and only give medications to those who will have good responses. This was sometime in the future, except the future really is now when it comes to pharmacogenomics. The FDA, their list of medications for which now they recommend genomic information be acquired is growing steadily each and every year. And increasingly, we are seeing cases being really used in the clinic where pharmacogenomics is becoming standard of care. I will tell you, when we hear and we see what comes into the Institute as pilot ideas for taking genomics and really applying it medically, clearly, cancer and pharmacogenomics are the ones we hear most frequently, are the ones ready for significant testing. Which actually nicely leads me to my third hot area of genomic medicine, what I refer to as test drive programs. We and other funding agencies certainly recognize that genomics and its applications to clinical medicine are not hypothetical. It really is ready for test drives out in the clinic. And so we have now put into place 2 different programs that I call our genomic medicine test drive programs. And again, pharmacogenomics and cancer are featured in many of these, although there are other areas being studied as well. The first of these programs is called the Clinical Sequencing Exploratory Research Program. This is now part of our large genome sequencing program, but the first one to really stick a toe into the clinical realm. We've now funded 9 programs to date, or 9 groups that are specifically addressing the question of, can I take genome sequencing as part of a diagnostic or a component of patient care and take it out for a test ride? Really do it, study it, and learn from it. And we recognize that this is going to be very valuable, and not surprisingly, the Cancer Institute has partnered with us on a couple of these because of the obvious opportunities in cancer genomics. But there's some situations where it has already been clear that this works, that genomics and genome sequencing in particular, and genomic information is valuable for clinical care. but now disseminating that practice to other sites, other healthcare delivery systems, other circumstances, other settings, other communities. And sometimes that's not so easy. So we just started a new program just a couple months ago called the Implementing Genomics in Clinical Practice, or the IGNITE Network. We've now funded 3 groups, and we'll fund more in the future, that are looking to take case examples that have been successful and figure out what is the best way to disseminate best practices and seeing it adopted at other places to make sure that the success stories in genomic medicine find widespread dissemination when appropriate. The fourth hot area, I would say, in genomic medicine is again, you've heard a little bit about already, newborn and prenatal genomic analyses. In the case of prenatal, you've heard extensively from several speakers already the excitement that's going in now, especially with non-invasive prenatal testing. These have won awards and have been acknowledged really over the past couple of years, and some of our grantees have been instrumental in pushing this forward, especially our grantees who are funded for doing technology development and DNA sequencing. And indeed, this is finding its way into the popular press as well, and as you've heard, companies are moving forward fast and furious on this. It's a very exciting opportunity that really is recognized as some of the earliest fruits of the success of genome sequencing for diagnostics. The area that we just launched a new program in, and you even heard from some of the panelists, is a more complicated setting, relates to the newborn period, where newborn screening is part of the standard practice in most developing countries these days. But the notion of doing newborn sequencing has many more complexities, both logistical complexities and also ethical questions that clearly need to be examined. So partnering with the Child Health Institute at NIH just this past fall, we launched a new consortium of investigators who will now be studying this over the next few years to really understand what does it look like to actually do sequencing of newborns as part of their routine care. And the kinds of studies that are now been funded, we think, will provide important data to add to this conversation. The fifth area, which we think is certainly very hot, relates to just understanding what all this means and the need for clinical genomics information systems. Many of you have probably seen this cartoon, but it's a very real one. Sure, we can sequence the genome of any patient in the hospital, but whether we really understand what most of that sequence means is actually quite questionable, and the poor practicing healthcare professional simply doesn't have time to be able to go through and understand what the number of variants that each individual carries and what it means for them clinically. So I've certainly heard loud and clear for the past 4+ years I've been director of NHGRI that we need more powerful systems. We need to make this a reality, and Jay Flatley certainly echoed this as well in his talk. We need this to better integrate with electronic health records, and we need to develop better systems for practicing healthcare professionals with all the demands on their time can simply look up what are the variants relevant for these patients and what does that look like. This is going to be a Herculean task, and first and foremost, we need to research what are the processes that are going to be needed to take this tsunami of information about clinical variants in patients' genomes and what it really means for the practice of medicine. So through a number of moves, we've put together something called the Clinical Genome Resource, which literally is just getting off the ground. We're doing this again in partnership with the National Center for Biotechnology Information and also the Child Health Institute. And I will tell you, one of the early grantees of this effort is just down the street here at Stanford. And their mission is to help start laying out a research agenda that will start to teach us how we are going to, over the coming years, understand what all these variants mean for actual clinical practice. And first, by developing a knowledge base of information, and then we can think from going on from there to figuring out how to make the kind of tools available to practicing healthcare professionals for understanding what variants mean in their individual patients. And the sixth and last area, again, you've heard about already, relates to ultra-rare genetic disease diagnostics, the diagnostic odysseys that we hear about and increasingly the popular press are picking up on as well. The notion of having a patient with an ultra-rare genetic disease that has been clinically worked up without a diagnosis and now simply sequencing their genome as part of their routine care is no longer new. In fact, I will show here a number of review articles that have already been written over the past couple of years laying out this idea that in fact it is a sort of standard of care now almost for these ultra-rare cases to at least try to do a genome sequence and see if that can be revealing to provide a diagnosis. One of the prototype programs that exist for this, although there are others, and you heard about some of them, is in the NIH intramural program, the Undiagnosed Diseases program. This has been quite successful at bringing patients to the NIH where diagnoses have failed to be revealed based on their initial workups in multiple other places. Almost always this involves genome sequencing of these individuals, and in a good fraction of the cases we're able to figure out exactly what is wrong. Not all cases, but we need to learn more about how to do that, and it seemed that it was time to do something even broader than just having the program at NIH. And so through the NIH Common Fund, a new program has been created called the Undiagnosed Diseases Network, which aims to build on the successful experience with the NIH Undiagnosed Diseases Program to improve the diagnosis and care of patients with undiagnosed diseases, facilitate research into the etiology of undiagnosed diseases, and most importantly, to create a highly collaborative research community to identify best practices for the diagnosis and management of undiagnosed diseases. Later this year, we envision naming about 5 or 6 new centers around the country that will be part of this network. We'll work with the existing program at NIH and have this be a national network, if you will, of centers that will focus on ultra-rare diseases and using genomics in particular to end the diagnostic odyssey for these patients. So those are the 6 areas I wanted to tell you about, and in fact, that's mostly what I wanted to tell you about in this short time I have here. What I would say, at a personal level in particular, I've been involved in genomics starting shortly after I graduated medical school. I got involved in the Genome Project on day 1. And what I will tell you that when the Genome Project began and I was there, I remember, I think the whole idea of how this would ever be clinically relevant was really quite blurry. And even when the Genome Project ended 10 years ago, and I think you heard something similar from some of the panelists, maybe we had some vague ideas, but I think it's hard for any of us to say we really understood what it was going to look like. But I would certainly tell you that as we published our strategic plan, I think we're getting increasing clarity of what this is going to look like, and I predict by the end of this decade, we won't have fully implemented genomics in the clinic, and we'll have a lot more to learn, but I think it'll be much clearer what the future is going to look like for genomic medicine. So I will end there, and I will thank you for your attention.